Welcome to the BMJ podcast. I'm Cameron Abbasi, Editor-in-Chief of the BMJ. This week we're focusing on women's health. Firstly, breast cancer screening. The US Preventive Services Task Force has recommended a decrease in the age at which women are invited to be screened. We'll hear why this might not solve the problem they are trying to fix and may actually cause harm.
That motivation is uncontestable, but it's really easy sometimes to take actions with a motivation in mind that don't actually do what that motivation is seeking to achieve.
Then, epidural injections during labour. 22% of labours in Scotland included an epidural. But research in the BMJ has shown that epidurals may reduce maternal morbidity, and we'll find out why.
Clinical practice as anaesthetists, we're generally quite keen when women we feel are at higher risk of having complications during labour. We're generally quite keen that they have an epidural, but it struck me that there wasn't a huge amount of data or research to back that up.
Finally, many doctors might wish they could give the Prime Minister a piece of their mind, and one lucky GP was able to do so.
The NHS is disintegrating. I am one of 2,500 GPs in this country who are currently unemployed due to your policies. What are you going to do about that?
The US has new breast cancer screening guidelines. They have lowered the age at which women and other eligible people are invited to take part from 50 to 40. However, at the same time, Canada has gone in the opposite direction and said that women in their 40s who previously would have been invited for screening should now have an informed conversation with their doctor and make their own choice. A new editorial on bmj.com discusses this discrepancy, and two of the authors spoke to Duncan Jarvis, our producer, about this very issue.
I'm joined now by Stacy Carter and Katy Bell. Katy, could I get you to introduce yourself?
Sure, thanks Duncan. So I'm a Professor of Clinical Epidemiology at the University of Sydney's School of Public Health, and I have expertise in evaluating the clinical effectiveness of healthcare with a particular interest in sustainable healthcare.
Thank you. And Stacy?
Thanks, Duncan. My name's Stacy Carter. I'm a Professor of Empirical Ethics in Health at the University of Wollongong, and I run a research centre called the Australian Centre for Health, Engagement, Evidence and Values. Our focus is really on how we can connect policy to communities and get policymakers to listen to what matters to communities in a health context.
And I should add that we're both investigators with the Wiser Healthcare Research Collaboration, which is a much larger Australian research group that are working to try to prevent overdiagnosis and overtreatment.
And I was going to say, and you're bringing two very different but interesting viewpoints to this. Katy, maybe if we could start with you, could you just talk us through what's actually happening?
So that the focus of the change is primarily on the age change in the recommendation. So previously there was a recommendation that women in their 40s should undergo shared decision-making with their physician, and that's changed to a stronger recommendation that all women in their 40s should commence biannual screening. It does seem that the US is an outlier compared to other countries. So often other countries such as Canada and Australia allow screening in the 40s, but it's not a strong recommendation that all women should start screening then. And that's the case with a lot of European countries, although there are some European countries that do screen a lot less and still have very good cancer outcomes for breast cancer. But yeah, it's the strong recommendation that all women should be screened in their 40s, which is really setting this new US recommendation apart from most other countries.
In writing the editorial, what Katy and myself and our colleagues were really concerned about is that the main focus should be outcomes. So screening is a really helpful intervention in situations where we know that the benefits greatly outweigh the harms. And screening is a very attractive intervention because you can recommend it to a whole population. It seems relatively straightforward. And so using that as a solution to disparities in cancer outcomes, you can see how that's intuitively quite attractive. We'll just increase the number of people that are participating in screening, and that has to be a good thing. And it's quite common for groups that advocate for particular diseases, for example, people that are involved in breast cancer advocacy, to always be advocating for more screening of more people, screening of a wider age range, working harder to get more people to participate, potentially screening more often, because that's what intuitively feels like should improve outcomes if we believe that screening is a good thing.
And in your editorial, you mentioned that this isn't based on new empirical evidence, but it's perhaps to do with trying to capture populations who may be more vulnerable.
Yeah, so it seems that is the motivation for expanding the screening recommendation, is to try and improve health equity for underserved groups, particularly Black American women. However, the approach taken to achieve that seems, in my opinion, to be a bit questionable as to whether that will actually reduce disparities and increase equity.
The problem here is that there doesn't seem to be any evidence that screening all American women in their 40s will do anything much to improve outcomes for Black American women. And that last part, improving outcomes for Black American women in respect of breast cancer, that has to be the focus, because really those outcomes are worse. So we know that about 28 Black American women die for every 20 women per 100,000. So there really is a difference in mortality, but screening more is not the thing we think that is likely to make a difference to that mortality difference.
Outcomes being directly linked to screening is quite hard to put together here. Presumably there could be other things going on for Black women. It's not about the invitation to screening that's really the cause of that.
But yeah, like it definitely seems that it's all the things after a diagnosis which need to be improved, and particularly symptomatic cancer diagnoses. So timely access to like effective care that's like the best evidence-based treatments, and more broadly addressing, I guess, social determinants of health.
So it seems like this is potentially has downsides as well as being ineffective, but yet the decision has been made. So what was it that's changed here? You mentioned in your editorial that there's been some modelling done.
Yeah, so I think the microsimulation modelling, so it was a collaborative modelling group, and obviously very detailed modelling that was done and a lot of work that went into there. But it is a simulation, and so it's not actual real life evidence, and makes like a number of like quite unrealistic assumptions that probably, it seems like if you compare the results of the modelling to what the empirical evidence showed, it's comes up with like quite a lot larger benefits for the modelling. So it seems, it's a bit of a worrying development, because it did seem that maybe there's been a bit of a change in how the US task force is valuing these different types of evidence, and that they're now basing decisions like this one primarily on the modelling evidence rather than what the empirical trial evidence is actually showing.
I think the tricky thing about this decision by the US Preventive Services Task Force is that it seems to have come from really good and really important motivations. At least the way that it's described, it's about trying to address a fundamental inequity and wanting to do something about systematic racism in the US healthcare system. So that motivation is uncontestable. But it's really easy sometimes to take actions with a motivation in mind that don't actually do what that motivation is seeking to achieve. And in doing that, to not look hard enough at the unintended consequences. So this is things like false positives, which don't sound like much, but it can mean a woman on a really low income or a woman with a lot of dependents having to give up a whole day and have a very invasive procedure to check whether she actually has cancer or not, and to have to wait for weeks to be able to have that appointment and have all the worry and anxiety that is caught up with that waiting. A false positive is not nothing. It's a really significant experience, and overdiagnosis is an even more significant transition for people. It turns people from healthy people into cancer survivors and puts people through potentially really invasive treatments. So if it was super clear, even if it was marginal actually, that this expansion would harm about the same number of people as it would benefit, then maybe that's an important conversation to have. But in this age group in particular, those really significant harms are greater than the potential benefits, and the benefits are really uncertain. They can range from saving a few lives to actually reducing, so leading to more deaths rather than fewer deaths. So the range crosses zero. It's actually quite an uncertain estimate of the benefit. So that's a very significant commitment to make, particularly when you're talking about a program that potentially then is rolled out to the entire population. If you're going to encourage people to participate in something, you need to be really sure that you've got the evidence to back up that encouragement, because you're potentially doing a lot of harm to a lot of people.
And just to follow up on that, so the false positives are particularly large for this age group. It's larger for women in their 40s than any other age group. And it's not just the anxiety and psychological harms at the sort of lead up to the further diagnostic test, but there's actually studies showing that anxiety persists for years afterwards, and that the woman perceive that there is something wrong still, even though the definitive diagnostic test said, no, it's all fine. They still perceive that they're at higher risk and that they need to have more screening. And so the false positives particularly seem to be a really significant harm in this age group, I think.
We're talking about a change in guidelines in the US, but this could potentially have some ripple effects around the world.
The US Preventive Services Task Force has this quite iconic position in the international community, and particularly for policy services or governments that don't have a lot of funding and don't have a lot of support for doing the kind of in-depth decision making that might need to underpin this kind of policy change. That it might be quite tempting to think that we should just do whatever the US PSTF does because they're really well resourced and they've been able to look into what's right, and so we should just do what they do. So I think there's really a worry that this could be the first domino in quite a significant domino effect, and that could harm millions and millions of women around the world.
Even in countries like Canada and Australia, where there are resources to do the review of the evidence within the country, it still makes it more difficult to have a recommendation that's in opposition to what the US has said. And I think we're seeing that play out in the Canadian draft recommendations, actually, that there's, I understand, been quite strong pushback about their recommendation to not say that all women in their 40s need to go for screening. And that's been quite explicitly stated in relation to the US recommendation.
We're sticking with women's health for our next segment. We recently published a paper which found that epidurals can reduce maternal morbidity. But some of the people who might most benefit from them are the least likely to receive them. Rachael Kearns is one of the authors, and Duncan Jarvis, our producer, spoke to her about their findings.
Yes, hi. My name is Rachael Kearns. I'm a consultant anaesthetist up in Glasgow Royal Infirmary and an honorary professor at University of Glasgow. I'm sure we've all seen in the press the sort of rather harrowing statistic of the rising maternal mortality rates. We have seen raising rates of maternal morbidity. And I know just from clinical practice as anaesthetists, we're generally quite keen when women we feel are at higher risk of having complications during labour. We're generally quite keen that they have an epidural, but it struck me that there wasn't a huge amount of data or research to back that up.
So that's why you've decided to do this study. Now, it's based in Scotland and you're using observational data that's routinely collected for it, right?
So we have a data set of NHS administrative data. So these are data collected for every woman in Scotland who's given birth. So I'm in that data set a couple of times. Everyone in Scotland, there's no selecting out who's in it. Everybody's in it. We've got linked data for both mother and baby, which makes it quite a unique data set. But because it covers every woman who's given birth, it gives us vast numbers of patients to look at.
So you've got this really good representative data sample there, and your outcome measure was quite a broad one, severe maternal morbidity. What does that include?
So it can be defined in different ways, but essentially it means a serious unintended consequence of labour and delivery, which will have long-lasting implications for a mother's health. So we use the definition from the CDC in America, and they define it as one or more of 21 conditions or procedures. So these are really major things like a heart attack or a stroke or a PE or an eclamptic fit or a hysterectomy, something really quite significant that happens around the time of birth. So we used their definition, and we also included critical care admission in that definition as well, just to encompass any other causes of severe harm that weren't included in that sort of specific definition.
So you've got this broad data set to encompass as many women as possible. You've got these broad set of outcomes to encompass as much harm as possible. When you analysed your results, did that hunch that you had at the beginning stand up?
When we did our analysis, taking into account any other sort of confounding variables, we found that yes, it did seem to have a protective association. There was a 35% reduction in all comers, so all women in our cohort, in the risk of severe maternal morbidity. So that was in all sort of just over 500,000 women. But what was really interesting to us anyway was that women who are at higher underlying risk of having an issue, so women with underlying risk factors for poor outcomes, seemed to have more to gain from having an epidural, and their risk reduction was greater at around about 50%. It's similarly for women that were giving birth prematurely. Again, we know those women are at higher risk of having poorer outcomes. They seem to have more to gain as well. So what we suspected clinically, what we sort of see day to day, what we believe to be true was borne out in the data.
Now, obviously, having good care during labour is important to outcomes. But what is it about the analgesia, and particularly epidural analgesia, that seems to affect such disparate group of outcomes? You can imagine, blood pressure shooting up because you're in pain and that causing issues, but there are so many things this seems to affect.
So that's a really good question. And I think from our data, we can't answer that. But what I can do is think about why, from my experience, as to why this might be the case. And I think part of it, you've hit the nail on the head. There are physiological changes that come with having an epidural. One reason we're quite keen that women with preeclampsia have an epidural is because of the blood pressure issues. Blood pressure is high when you're in pain and you're distressed. Bringing that down can be helpful and can reduce the risk of having complications. So reducing the catecholamine stress response that woman's going through, bringing the heart rate down, bringing the blood pressure down, particularly helpful in women who may have preeclampsia or cardiac conditions. But further to that, I feel that it really just puts you in a different starting place if something does start to go wrong. You start to find yourself in a scenario where you're going to need a bit of extra help. So let's say you have your baby and you start to bleed heavily and you're going to need some form of intervention. If you're bleeding in the room and you're nice and comfortable down below, the obstetrician may well be able to do some sort of temporizing measure to stem the bleeding because you're comfortable. They can try and do something to slow things down, or put a stitch in, or put a pack in, or do something while you get to theatre, and just change the direction your care goes in. Furthermore, if you do need an anaesthetic, let's say you need to get rushed to theatre, or you are bleeding and it needs operative management, we can induce anaesthesia more rapidly because you've got an epidural in place. If it's working well, we can top that up with stronger local anaesthetic and use that to give you your anaesthetic rather than having to put you off to sleep or do a separate spinal anaesthetic. So there's that as well. Further to that, there is the argument that there's probably a greater degree of medical oversight. You've got one-to-one midwifery care, you're having your observations checked regularly, you have a cannula in, you're getting IV fluids, there's other things going on. But when we did a sensitivity analysis just looking at obstetric units with 24/7 obstetric and anaesthetic care, where women generally don't just get stuck in a room and told to get on with it. In that analysis, we found similar findings to our main results. So I'm not sure it's all based on that. It's probably multifactorial, to be honest. But I think for me, it just gives you this different starting place to deal with issues should they arrive in a sort of sliding doors approach where the same scenario, one, in the woman who has an epidural compared to the one who didn't, can go in different directions because of that and try to prevent things from escalating.
Now, right back at the beginning, you mentioned the worrying statistics we have in the UK around maternal outcomes, particularly amongst Black women. Now, were you able to look specifically at them in your data set, and was this all borne out in the same way for that population?
So in this study, we adjusted for ethnicity, but we didn't look specifically at different ethnic strata. And Scotland's actually 92% white. We're actually not very ethnically diverse, which is a limitation of the study. But in other work that we've done, we did a paper looking at uptake of epidural analgesia in labour between women from different socioeconomic groups and in white and non-white ethnic groups. As I say, bearing in mind Scotland is predominantly white, so we couldn't divide things up in a more nuanced way. And we saw some really sort of stark, particularly socioeconomic differences in who was getting epidurals. So women from the most deprived areas were 16% less likely than women from the most affluent areas to have an epidural. And actually, any socioeconomic gradient we saw was actually even more marked in the non-white ethnic mothers. So the women from non-white ethnic groups who were from the most affluent groups were actually more likely than their white counterparts to have an epidural, but those from the poorest socioeconomic areas were less likely than their white counterparts to have one. So it was a sort of really interesting relationship. And there has been other work done by other groups looking at ethnic differences in our interventions and our care and showing clear disparities, the reasons for which are not entirely clear, but are clearly alarming and concerning and have to be addressed.
And the use of epidural varies within Scotland, but it varies quite broadly between different countries as well. How does Scotland sit within that sort of ranking of epidural use? And do you think perhaps that it's in the right place there?
So in the UK in general, we tend to be low users of epidural. So our epidural rate in the study was about 22%, and that's in keeping with UK statistics of around about 20 to 25%, depending on what you read. But as you say, that's really in quite stark contrast to other countries. And in France, rates are well over 80%, even hitting the 90s. In the USA, again, we're looking into the 80s of percents. And when you consider that in the UK, we have a healthcare system that's free at the point of access. No one has to pay for an epidural. You can have one if you want one. That's quite interesting, and it's kind of hard to explain. And I do wonder whether in the UK we're kind of brought up with a culture of, labour sore, it's a bit of a badge of honour just to get on with it and have the baby without pain relief. And it's only when you really start to examine that belief and you sort of think, well, why? There's no other painful procedure that you would expect to have. If you break your arm, no one says, would you like pain relief for your broken arm? You just get it because it's really sore, obviously. So labour is one of those funny, bizarre situations where in the UK we seem to have different beliefs about what we do and don't think is okay. And I think to be honest, the root of this, there will be a number of myths and misconceptions about epidurals. I think one of the myths that is potentially a misconception actually amongst healthcare professionals as well is that epidurals make you more likely to have a caesarean section. And again, Cochrane review data would say that that wasn't the case. Now, it probably is true that epidurals are associated with having an operative type of birth, but that's probably more to do with the fact that epidurals aren't given out at random, and women who tend to ask for them tend to be those having a more protracted, longer, more obstructed, more difficult labour, and who are always more likely to end up in an operating theatre. So particularly given the low concentrations of local anaesthetics we use these days, the days of women being lying there unable to move, unable to push are long gone, or they should be long gone. Things really have moved on. So there's a number of things which hopefully we can provide reassuring information for mothers.
And now, given that in the UK, a lot of maternity care happens in primary care before someone will meet an obstetrician, do you think that there needs to be conversations earlier in that process about epidurals and the risks and benefits and the woman's choice about whether to have one?
I think that's a really interesting point. Antenatal education is really vital, and I think many women will go out and seek their own information. And again, maybe this is why we're seeing some of the disparities we're seeing, because those women who have a higher level of education or who know where to access resources, who have contacts who can point them in the right direction, may there be at an advantage. And it's interesting when you look to other countries. In France, every woman is seen by an anaesthetist antenatally to talk about options for pain relief, of which there are many. Epidural is not the only thing that you can have. There are different things you can have. And just having that information given to you by someone with that knowledge, I think, would be incredibly powerful. Now, obviously, we don't have that yet in the UK, and the resource for that would be enormous. But what I think is really important, not everyone is going to be an expert on labour analgesia. It's a big topic. But what you can do is signpost women in the right direction. And what I would really recommend people use or direct their patients to if they're in primary care is the Labour Pains resource from the Obstetric Anaesthetists Association. It's available on labourpains.org, and it's absolutely fantastic. It's got all of the information you need to give to mothers. So I think that's a step in the right direction.
Finally, who wouldn't like to give a Prime Minister a piece of their mind? Jane Lees-Millais got the chance to do that on national television, and she spoke to the BMJ about why she felt she needed to speak out.
Wages have been rising faster than prices for almost a year now, and that shows that we're on the right track.
But the NHS is disintegrating. I am one of 2,500 GPs in this country who are currently unemployed due to your policies. What are you going to do about that? 37,000 GPs will not vote Conservative because of the constructive dismissal of general practice that is currently occurring. Well, you cannot employ lesser qualified people instead of GPs. They cannot be replaced. The country is not stupid.
Well,
they know when lesser qualified people are being used.
This is amusing. I was invited by the Conservative Central Office. I've been a Conservative Party member for years. Sometimes I've joined other political parties as well. And I'm currently a Conservative Party member, yeah. So I said, oh, yes, very good, because I like getting to that kind of thing and speaking my mind if I can. And standing there with quite a small bunch of people, about 40 ordinary people. And lo and behold, the Prime Minister came out. And I thought, well, he's still only a minister. And he's still only a man, and he does not know what's going on. So I went for it.
Now, if you just mind, so my dad was a GP, but my mum was also a pharmacist. So that's the household I grew up in. My parents dedicated themselves to primary care. I know a thing or two about it. I worked very hard in my mum's pharmacy. And whilst we're supporting GPs, and actually right now supporting them with investment in digital telephony to make sure that we can make it easier to get access to them, we are also making it easier for people to see other primary care practitioners to get the treatments they need. And that's where I'll respectfully disagree with you, because I do think it is right that people can now see their pharmacist to get medicines for seven common ailments like sore throats, ear infections and sinusitis. And that is an example of something we're doing, making it easier for people to get the care they need. But I will always support primary care, as I said, because I'm the son of both a GP and a pharmacist. But
I see no reason. Well, he was completely unable to answer what I said. And then after a little pause, he began to talk about how he had helped his mother in the pharmacy. But that was a very, very long time ago. And pharmacists, without a doubt, have a position there, and they know their limits and they do what they can. And we are just so glad that they take some of the weight off our back. But they can't take it all. They can't take the majority, and they can't handle complex work. They're not trained for it. Why should they?
That's it for this week. Links to all this week's articles are available with the episode. Next time, we're having a patient takeover of the podcast and the whole BMJ. Subscribe wherever you listen to podcasts. I'm Cameron Abbasi. Thanks for listening.